Hi, this is Brian Kim. I'd like to share with you a case of Ectopia lentis and how I approached it. So this is a patient with Ectopia lentis, and this is the most important step. You want to mark the central cornea, and this is not just for centration, but also, more importantly, to determine the size of your capsulorhexis. Puncturing the capsule in a soft lens can be difficult, and so using a cystotome to puncture is helpful. You want to also decenter your capsulorhexis, in this case more towards the right, because that's actually the center of the capsular bag. Because the landmarks are not typical with normal cataract surgery and because the lens is decentered, it's easy to get disoriented and make your capsulorhexis too large. And having a large capsulorhexis doesn't make the case impossible, but it does make it much more difficult. You need the anterior capsulorhexis rim to provide that structural support, or in case you need a capsular retention segment or a capsular retention ring. This will provide this, retract the capsule, center this lens better. I prefer capsular fornix hydrodissection, and as you can see, the cannula is placed out to the fornix and pointed downward, and a very easy flowing hydrodissection wave is performed. You massage the lens and decompress the bag so that there is no capsular block. And as you can see here, I'm going to sweep underneath the anterior capsulorhexis edge to the right and to the left, and this just helps loosen up the lens in a very controlled manner. And so lens material removal is very easy in this Ectopia lentis situation. The lens is very soft. This is in a fairly young gentleman. And again, in this patient, the area of defect and weakening is in a particular sector in this patient. And so we're going to try to do everything we can to center this bag as best as possible. I don't want to invite any vitreous into the anterior chamber and around the zonules in the area of defect. And so I like to perform a fluid exchange. So when I take the phaco hand tip out, I like to place BSS through my paracentesis while I'm waiting for the INA tip. And this helps to minimize potential prolapse of vitreous into the anterior chamber. I always perform INA focusing on the subincisional cortex first. I have the polymer tip, which gives me a lot of confidence that I won't rupture the bag during any of my maneuvers. Since the zonules can be weak, it's helpful to perform a tangential right to left sweeping motion when you're teasing off the cortical remnants from the capsule. Rather than pulling centrally, you want to sweep side to side to gently tease the cortex from the bag. And again, to prevent vitreous prolapse, I like to place the Provisc into the capsular bag and into the anterior chamber before I withdraw the INA handpiece. And now I'm preparing my capsular retention ring for insertion. I'm using a Sinskey hook to help open up my incision, and then I'm going through my paracentesis. In order to minimize any trauma on the zonules, I'm going to hook the leading eyelet of the CTR with the Sinskey hook, and as I advance the CTR, I'm helping to pull the leading eyelet towards me, which will help minimize any torsional traction on the zonules. And now a 3-piece intraocular lens is going to be placed within the capsular bag, and we will just assess and see how this centers once I place it in there. I'm using a Maltzman instrument now to gently dial that 3-piece haptic into the bag. But unfortunately, the lens is not well centered, and as a result, a traction suture is being placed away from the area of zonular weakness. And I will pull the eye away from that area to expose the conjunctiva and the area of dissection that I need to perform. I'm performing a piridomy to help expose the sclera, and I'm applying light cautery in this area. After gentle cautery is performed, I am marking about 2.5 millimeters posterior to the limbus, and I'm going to use a diamond blade to create a horizontal incision parallel to the limbus in partial thickness to the sclera. And then I'm going to pierce through the sclera with my diamond blade. I'm going to thread the needle of a 7/0 Gore-Tex suture through the eyelet of a capsular tension segment, and then I'll cut the needle off. And then I'm going to carefully place the capsular tension segment through my main incision, and then I'm going to place a micrograsper through a paracentesis incision and very carefully grasp the capsular tension segment and tuck it underneath the anterior capsular edge and into the capsular bag. And you want to make sure that the eyelet is facing exactly where my sclerotomies are going to be, and that is going to be the location where I'm going to externalize the sutures. You can see I'm placing a micrograsper through the sclerotomy, and with another micrograsper through the main incision, I am handshaking the Gore-Tex suture from one forceps to the other. I'm performing a similar procedure for the other end of the suture by grasping from the micrograsper, holding the suture through the main incision, and then handing it off to the micrograsper through the sclerotomy. Suturing Gore-Tex can be tricky and unforgiving. You can accidentally make the suture too tight, or you can make it too loose. Therefore, you want to perform a slip knot, essentially a single throw, in order to be able to adjust the tension of your suture. After you've determined the appropriate tension, you can put a few more throws in and cinch it really tight to lock the suture. And then I'm going to bury the knot of the suture through the sclerotomy. I'm going to close the sclerotomy using vicryl suture in interrupted fashion on each side. And then I'm going to close and reapproximate conjunctiva with the same vicryl suture. As you can tell, the lens is perfectly well centered, and that is because of the slip knot Gore-Tex suture. Now, when looking at the capsular tension segment, the only reason the capsular tension segment is able to hold and stretch and support the capsular bag and the zonules is because there's significant anterior capsular support. And so that is why if you make too much of a large capsulorhexis in these cases, it can be a much more challenging situation. You want to make a smaller than intended capsulorhexis so that you can have enough anterior capsule support to be able to secure devices such like this capsular tension ring and capsular tension segment for scleral fixation. As you can see during the INA and removal of viscoelastic, the lens is very well stable. I'm tapping the lens with the INA tip, and you can see that the lens is not moving side to side in any way. And I'm hydrating my wounds at the end of this case. So these are my pearls on how to deal with these cases. I hope this was helpful to you, and thank you for your attention.